we started this day, day one, talking about automation tools and what research can offer. You've seen many offers, anything from as simple as structured templates to more advanced tools as deep learning planning and then putting all together in Plan Explorer. So we have that at research, and but it would make no sense just to have them staying inside the company. Of course, our users should be using them, and that's why we would like to show you the real examples of how our automation tools are being used as today. So that's why we asked our guests to join us. So please welcome everyone. Sherif coming here today from MD Anderson Comprehensive Cancer Center. Hello, Sherif. How are you
Hello,
doing?
how are you?
I'm very well, thank
Thank you
you.
very much for the
We're
introduction.
we're super excited to have you here. I think it's extremely important to see how automation can benefit clinics. And we will see that today with your talk, since you will be giving your expertise and knowledge within scripting and automation workflows. So please go ahead.
Thank you very much. Hi, everyone. My name is Sherif Gadoue, and I'm a proton physicist at MD Anderson Cancer Center. And I would like to thank Research for inviting me to present my work. And that work involves automation of our workflow for CSI patients. And we were able to cut the time from simulation to treatment by a factor of 3 or 4. And in this presentation, and I'm going to show how we did this. Um, First, disclosure. I have nothing to disclose. And then the outline. That is what I'm going to talk about. I'm going to start by giving an overview of the CSI workflow. And then I am going to describe in detail the 6 scripts that we currently use at our institution to automate our CSI workflow. And then I'm going to conclude by giving a brief summary of the current work and the ongoing work and future work. So let's get started. Oops. Something is... All right, going back to CSI, craniospinal irradiation. As everybody know, CSI plans are very attractive. They are very good looking in proton therapy. You can see that the dose is conformal. We have much less integral dose compared to photon plans and VMAT plans. But everything comes at a price. The very first thing is patient load. In the average, the workload for CSI patient is around 7, 10 to 15% of the workload in the clinics. And that's considered a non-negligible portion of workloads. But the main problem here is planning. And as you know, planning is very complex and time consuming because we do a lot of manual work. And because we have a lot of manual work, it's an error prone. So we have to do something to automate the process, to reduce error, and cut time. From simulation to delivery, on the average, it takes 10 to 14 days to get patient ready for treatment, which is significant. In order to solve this problem, we came up with an implementation of automation-driven CSI workflow at MD Anderson, and that consists of 6 scripts. And the first script is going to draw the external and insert the couch for the patient. That happens usually after the dosimetrist import the CT of the patient. Then we have the second script, which is the most important aspect of the CSI workflow because it reduced the most amount of time. We're going to talk in detail about this auto plan script. And then we have the plan check script that check the generated plan All right, and then we have a beam set split script. The beam set split script will technically divide the plan into beam sets to make it ready for the export. And then we do the final checks and the export of the plan to the treatment delivery system. And finally, we are going to talk also about the auto QA script. And that is also another important aspect of the automation of our workflow because it reduces a lot of time. First, the external script, uh, the easiest part of the workflow. And we have this script at MD Anderson, and it functions two things. The first thing is to insert the proper couch for the patient, and each treatment site has its own couch. And then it generates the external contour. As everybody is aware, the external contour can be created using a threshold for Hounsfield unit. For each treatment site, we have some defaults. For head and neck, we use minus 450 Hounsfield units. For other treatment sites, such as prostate, we use negative 920 HU. So we keep these default values. But in case we have some different anatomy patients or the dosimetry need to change a little bit in the contour, or we have challenging cases, we have a user-defined HU value that the dosimetrist can insert in here, and we can define the new contour based on this user input. Once we get this done, we keep getting that same. Yes, we are back. Okay. Next step, the auto plan script. And as I mentioned, this is the most important aspect of our automation on the workflow. And what happens is when you run the script, it's going to display this GUI to the dosimetrist, and the dosimetrist is going to fill the numbers of the prescription, the number of fractions, the target, and the plan name. And once they hit OK, that starts the first phase of the script. And it's going to auto-populate all this information to the plan, and it will set the default parameters, the optimization settings, the computation settings, the dose grid, and it will create the setup fields as well. So that acts as a template for starting the plan. Once we get this phase done, we go to the second phase of the auto plan. And in this phase, we create planning structures. If you are familiar with CSI, the manual way to do this is to run the optimization for few hours, like 4 or 5 hours. And then from this run, you figure out how the junctions need to be drawn, or how can you create these structures from the first run. Fortunately, we come up with an algorithm, and we can do this automatically. You don't need to run. And first save now is 4 hours. We are saving technically 4 hours without starting to do anything yet. And once we start to draw these junctions and create these structures, we go to the third phase, which consists of going to 3 rounds of optimization. The good point about this phase is that it saves idle time. And why is that? Because for each round of optimization, when you try to get rid of the cold spots, or you get rid of the hot spots, or you do the final check for the objectives, you have to run it for the first round, and then you wait until it finishes. Sometimes it finishes late in the night, sometimes it finishes early in the morning, and then when the dosimetrist is aware of this, we already lost like 2 hours. The good thing about the auto script is that it goes through these 3 rounds right away. So we are not only saving time, we are saving idle time. Um, Next, once we have a generated auto plan, we need to check it. And as they say, with automation, there is always a responsibility. You have to check that the script is doing what it's supposed to do. So we compiled a list of errors that might happen or errors that already had happened in the past, and we included this list in our checks, and we check for different things. We check for the calibration curve used for the CT, and we check for the couch and the type of couch, and the optimization settings and the computation settings. We also check for the prescription and the prescription type, and we do some MU checks. On the other side, as you can see from here, technically, the plan check script is not only one script. There are two scripts. And the reason for this is because we have two proton systems at MD Anderson. We have PTC1 and we have PTC2. And the reason I'm mentioning this is we have to make sure that the patient who is treated and planned in PTC1 has the settings for PTC1, not the other way around. So this is very important. This is responsible to make sure that the patient is treated with the same settings needed for the proton system. After we make sure that the plan is good and it passes the physician review and it's ready for processing, comes a beam set split script. The usual way to plan CSI patients is to have all the combined fields together with different ISO centers in the same plan, all together. You check that those distribution is good, you get the physician approval, then you can move to the next step. And the next step is to convert all the fields that share the same ISO center and make them in one plan and export the plan. So what we do here is we are using the nice feature from RayStation, which is the beam sets. So we combine the fields together that have the same ISO center in different beam sets. So the script will generate the final plan, and that plan will consist of the different individual beam sets that share the same ISO center. And for each individual beam set, it will add the prescription, it will copy the fields from the base plan, and then it will adjust the imaging field for each beam set, calculate the final dose, do another round of checks for the MU with the base plan to make sure that after copying the plan, nothing has changed. Actually, this is for a typical patient with 4 beam sets or sometimes 5 beam sets. It takes more than 1 hour. So we are saving all this. You don't need to check because we are checking within the script. So remember, we saved idle time. We saved 4 hours of creating structures, and we are saving here 1 hour. Once we split the beam sets, we are ready now to export the plan. So we need to export the plan to 2 destinations. The first destination is to the treatment machine, and the second destination is to our QA system. And I'm going to talk about our QA system in the next slide. But for here, we are exporting our plan to the treatment delivery. And we got originally the script for exporting the plans from RayStation. Would like to thank them for doing this for us, but it has been modified to fit the needs of our system. Again, as we have 2 proton systems, we have 2 separate scripts. One will export for the first system, and one will export the plan for the second system. And the good thing about this script is we are not just exporting the plan, we are checking. Because this is considered as the last point of sanity checks before patient treatment. So we double check again, we double check our MUs, we double check the prescription type, and on top of that, I added a GUI for like a progress bar, because manually before doing this, we used to export and it takes around 5 minutes. And during the 5 minutes, the dosimetrist is sitting there not knowing what's going on behind the scenes. So I prefer to add this GUI, and as you can see here, it tells you what is happening. Are we exporting a backup? Are we um, exporting the first beam set, the second beam set, which field are we doing currently some checks? So it will give you uh, an indication of what's happening behind the scenes. Now, in my opinion, the auto plan script is wonderful, but this is also more wonderful. Okay? And the reason for this is multifold, and I'm going to tell you why. We did some analysis for our patient QA process, and we gave an estimate for each sub-process for the patient QA, and we found out that we need around 59 minutes. I don't know why it came out 59 rather than 60, but let's assume it's 60, okay? So all these processes take 1 hour. And if we add the time that we need to measure the treatment fields, let's say 10 to 15 minutes. So with this automatic patient QA script, we are reducing the time from around 70 minutes to only 10 minutes. So what actually happens is you run the script, you do the measurement, and everything is done. I remember maybe 2 weeks ago or 3 weeks ago, we had 30 patients. So doing this calculation, if you have 30 patients with around 50 minutes, 70 minutes per patient, so we need to finalize 30 patients QA during the weekend, we need 40 hours. If you have 2 physics assistants working Saturday and Sunday, that needs 10 hours per day to finish our QA. Imagine you have 10 hours per physics assistant to finalize all of our patient workload during the weekend. That is a lot, especially that it's done during the weekend. It's not very convenient. And the good thing is, that week, the patient QA was done in less than 1 hour. Because technically, what you have to do is very simple. Put the metrics, do the measurements, and everything is done. So quickly here, that is an example of what you get when you run the script. And the script is doing a lot of things. First, it set the isocenter depths. It creates a verification plan. It creates a folder for each patient in our QA directory. It export the DICOM files, generate the delivery files, at control point, the spot files, everything. And it creates the measurement folder, which is this folder. And in this folder, we put our metrics measurements. And in addition, we are using RayStation not just to check things within RayStation. We are using RayStation and the scripting within RayStation to help us in our system. And we are doing this by also, during the script, we are exporting the plan files that needed by our in-house QA system, which we call H plus QA. So in order for H plus QA to produce the final QA document, it needs the parameter and the measurements. Physics assistant provide the measurements. RayStation and the script provide the parameters. And what happens is, when the physics assistant finalizes the measurement, in this folder, our QA system automatically generates the QA document for the patient. So I would say it's not automatically, I would say automagically creating the QA document. So I'm done here. I just want to say the conclusions of our work. Several scripts have been developed in MD Anderson to reduce errors and automate the time-consuming and the error-prone parts of our CSI workflow. And this has improved the efficiency and consistency. And I would like to just stop for a minute here for consistency. What happens from the automated plan generation is you're not only reducing time, but on top of this, you are standardizing, okay. You are standardizing the patient care path, which means that regardless of the dosimetrist, regardless of the physicist, regardless of the physician, you are getting the same quality plan with the same workflow that we use the same auto plan script with the algorithm that we developed in these scripts. So that is very important to mention here. So we have an improved efficiency and we have consistent plans. Also, we have a feedback system to improve the current scripts. So I'm not sure if we can go back in here. For example, you see here, you see version 5, and then you have version 9H. So that tells you a lot of work has been done. So we keep updating, we keep improving. We work by feedback system. If our fellow dosimetrists ask for some upgrade, some improvement, we do it. And finally, we are doing also some ongoing work to add more to our scripts, and we are adding to other treatment sites. Recently, we finished prostate patients as well, and there are plans to do the head and neck plans as well.